Hello and welcome to my channel. In this lecture we'll discuss the 8th and 9th cranial nerves, so let's begin. The 8th cranial nerve, or the vestibulocochlear nerve, actually it's two nerves united together, the vestibular nerve and the cochlear nerve. One concerned with the body balance, which is the vestibular nerve, and the cochlear nerve, which is for hearing. The vestibulocochlear nerves, also known as the auditory or acoustic nerves, convey the hearing sensation and balance from the inner ear to the brainstem, and their course actually after exiting the inner ear is very short. Once they exit the inner ear, they enter the brainstem. Now, the auditory pathways convey auditory information to the auditory cortex, which is the temporal cortex, as we studied before, and the vestibular pathways send information about balance to several locations. Also, don't forget that the vestibular nuclei regulate the movements or the balance of the eye movements, called the vestibulo-oculomotor reflexes, concern the vestibular nuclei. Now, regarding the ear, sound waves are collected by the ear pinna or the auricle, and to be funneled into the external ear, external auditory meatus to the petrous in the petrous temporal bone, as you all know, and the tympanic membrane, which is the eardrum, separates the external from the middle ear at the medial end of the external auditory meatus. You can see the external auditory meatus here, and this is the tympanic membrane, and this is the middle ear cavity, and this is the inner ear labyrinth. Sound waves cause the tympanic membrane to vibrate, of course, and the vibrations are transmitted through the ear ossicles to the inner ear. The ear ossicles are the malleus, the incus, and the stapes. The malleus is the one attached to the tympanic membrane. The incus is attached to the stapes, as you can see here. And by the way, these are synovial joints between the ear ossicles. And the stapes, which is the last bone, or the stirrup bone, is attached to the oval window, forming the entrance to the fluid-filled inner ear, which is the perilymph of the inner ear. Now, about the magnification of the sound waves, several factors, including first of all the ear ossicles, they magnify the wave impulse, but the most important magnification is due to the ratio between the size of the tympanic membrane and the oval window. Now, the size ratio of the tympanic membrane to the oval window is about 15 or 17 to 1, and the leverage through the ear ossicles is around 2, so the net result is 15 times 2. That is, the sound waves are amplified by a factor of 30 as they reach the oval window. And of course, you studied before that the tensor tympani and the Stapedius, they protect the inner ear from loud noise or loud sounds reaching the inner ear. The inner ear is the cochlea, the vestibule and the semicircular canals. Cochlea, vestibule, and the semicircular canals. Now this is the bony labyrinth. Inside the bony labyrinth, there's a duct continuous all over the inner ear, which is the cochlear duct in the cochlea, utricle and saccule in the vestibule, and the semicircular ducts filling the semicircular canals. The receptors is called the organ of Corti within the cochlear part of the inner ear, and they transform or transduce sound waves from physical waves into electrical impulses. This is the organ of Corti, composed of the tectorial membrane and the hair cells with the supporting phalangeal cells resting on a membrane called the basilar membrane, which is a side of the duct that traverses the inner ear. This is the duct that traverses the inner ear, which is filled with endolymph, similar in structure to the intracellular fluid, and surrounded by perilymph in the scala vestibuli and the scala tympani, which is similar to the extracellular fluid, means high concentration of sodium, low in potassium, and the endolymph is high concentration of potassium, low in sodium. The central processes of the hair cells constitute the cochlear nerve, as you can see here, and each cochlear nerve leaves the inner ear through the internal acoustic meatus, where it unites with the nerve from the vestibular part of the internal ear to form the vestibulocochlear nerve. They enter the brainstem at the junction of the pons and medulla in a region called the cerebellopontine angle, alongside the components of the seventh nerves. We can look at this here. This is the vestibulocochlear nerve with the nervus intermedius and the seventh cranial nerve just medial to it. Okay. The auditory pathways. This is the auditory pathway, as you can see here. This is section in the medulla oblongata. This is pons and this is midbrain. Okay, as you go up to the temporal cortex, where the site of the auditory cortex. Now, each central process of the cochlear parts of the vestibulocochlear nerve divide as it enters the brainstem. One branch goes to the dorsal cochlear nuclei, and one branch goes to the ventral cochlear nucleus. The auditory pathway ascend from the cochlear nuclei to the inferior colliculi. In the midbrain, as you can see here, and on their way to the inferior colliculi, they make synaptic connections in the superior alveolar nuclei, as shown here. Superior alveolar nuclei located at the level of the pontomedullary junction. The superior alveolar nuclei determine the delay between sounds from each ear, so they are used to determine the direction of sound, where it's coming from. The projection neurons synapse in the contralateral inferior colliculus, but those that synapse in the superior alveolar nucleus projects to both colliculi. Now, postsynaptic neurons project from the inferior colliculus to the medial geniculate nucleus of the thalamus. Remember that the lateral geniculate nucleus was in the visual pathway, while the medial geniculate nucleus is in the auditory pathway. And neurons project from the thalamus via the sublentiform part of the internal capsule. Again, to remind you, the retrolenticular part of the internal capsule was in the visual pathway, while the sublenticular part is in the auditory pathway to the auditory cortex in the temporal lobe of the cerebral hemisphere. The neurons constituting the auditory pathways exhibit a complex series of uncrossed and crossed connections, with decussations occurring at most levels of the pathway. So that's why it's difficult to lose the sensation of hearing centrally, because each ear projects to both cerebral hemispheres with a series of crossings along the auditory pathway. The superior olivary nuclei and inferior colliculi connect with the nuclei of the other cranial nerves controlling eye movements, as mentioned before, and with the ventral horn of the cervical spinal cord controlling the head movements to move the head towards the direction of the sound. And now the connections enable reflex responses to auditory stimuli, as turning the eyes of the heads towards and the head towards the source of the sound. Also, we have important connections with the area of motor nucleus of the seventh nerve controlling the stapedius muscle and the fifth nerve controlling the tensor tympani muscle. As you studied before, these two muscles, this is the tensor tympani, okay, and stapedius is attached to the stapes, as you can see here. These control or protect the inner ear from loud noises. So they are in control of the vibrations arriving to the tympanic membrane. They contract reflexly when the loud sounds are detected, and they stiffen the ossicles in the middle ear, damping their vibration and protecting the bones, delicate bones and mechanisms within the inner ear. This is a section in the middle ear cavity, as you can see here. This is the promontory produced by the basal turn of the cochlea in the medial wall of the middle ear, as you can see here, and this is the stapes, the stapedius tendon, and the tensor tympani tendon. The tensor tympani goes to the tympanic membrane, while the stapedius to the stapes, and each has a separate nerve supply for further protection of the ear from the loud noises. Now, the vestibular pathways, the vestibular labyrinth consists of the utricle and saccule, that monitor the static position of the head, and the three semicircular canals which detect movements or kinetic position of the head. The vestibular parts of the vestibulocochlear nerve originate from receptor cells in the vestibular labyrinth and join with the cochlear portion to form the vestibulocochlear nerve, and their cell bodies form the vestibular ganglion close to the end of the internal acoustic meatus. The central processes constitute the vestibular nerve. Most of these processes synapse in the vestibular nuclei of the brainstem, which make connections with the cerebellum, the spinal cord, brainstem, cerebral cortex, and also some pass directly to the cerebellum. The vestibular nuclei are the origins of the medial longitudinal fasciculus, the one that connects the vestibular nuclei with cranial nerves, and the vestibulospinal tract, especially the medial vestibulospinal tract, the one that connects the vestibular nuclei with the gray matter of the spinal cord as part of the lateral motor pathways. as you can refer to the lectures in neuroanatomy regarding the motor pathways. Damage to the vestibulocochlear and inner ear. This exhibits itself as hearing loss, and the hearing loss takes two forms: either conductive hearing loss or sensory neural hearing loss. Conductive, from the name conduction, conductive hearing loss involves the conduction of the physical sound waves to the inner ear, and the sensory neural hearing loss involves the receptors itself. Now, regarding conductive hearing loss, occurs when conduction of sound through the outer and middle ears is impeded by, for example, accumulation of water or buildup of excess wax in the outer ear, or infections of the middle ear like otitis media, or arthritis in the ear ossicles. As I told you before, the joints between the ossicles are synovial, plain synovial joints. All these can impede the movements of the bones and thus diminish sufficient sound conduction to the inner ear, while the sensory neural hearing loss occurs when transduction of sound is compromised. Transduction means the conversion of the mechanical impulse into an electrical impulse, and this is done by the hair cells. So damage to the hair cells of the inner ear will result in sensory neural hearing loss, or maybe damage to the 8th cranial nerve itself. Now, damage to the hair cells may occur during after using some antibiotics, but most frequently through age-related hearing loss, and this is called presbyacusis, or environmental nose damage, such as the failing to wear recommended ear protection, and this occurs more frequently among the rock singers because of the excessive rehearsals, especially when not wearing the ear protection. In sensory neural hearing loss, there is usually selective loss of certain frequencies, not to all frequencies, and especially to those high frequency sounds, and this is because the hair cells are arranged tonotopically within the cochlea. Tonotopically means that those hair cells that respond to high frequency are located at the base of the cochlea, while those responding to low frequencies at the apex of the cochlea. In old people, they suffer from presbyacusis, find it most difficult to hear female and children's voices because they are of a higher frequency than male voices. Now, for testing of the vestibulocochlear nerve, we use a tuning fork. First, you strike the tuning fork and hold it close to the ear. If the patient didn't hear the sound, so you place the base of the tuning fork on the mastoid process of the temporal bone, which can be felt just below the ear. If the sound now can be heard, this is because it's being conducting through bone to the inner ear. So in this case, the patient has conductive hearing loss. This means also that the inner ear is transducing sound successfully, or the patient wouldn't hear the sound in both cases, either when you hold the tuning fork close to the ear, or when you place its base on the mastoid process. If hearing difficulty is still encountered, so this means that most probably that this is a sensory neural hearing loss. So further investigation is needed of this condition, and is carried out by using special equipment which determine the range of frequencies lost and the sensitivity at each frequency. In the case of otitis media, which is inflammation of the middle ear, this affects the vestibular components of the inner ear. If fluid movement within the vestibule is stimulated by heating effects rather than actual movement of the head, and this is done by introducing warm water into the outer ear, for example, the patient will feel dizzy and nauseated because the brain thinks that the head is moving when in fact it's not. Also, in otitis media, produces a case in which there is swelling, pain, and redness and heat involved. The heat produced in inflammatory reactions can set up the conduction currents and movements of fluid within the vestibule that stimulate the receptors that determine head position and movement. This causes dizziness and nausea. Now we're done with the vestibulocochlear nerve. Let's go to the glossopharyngeal nerve, which is the 9th cranial nerve. The glossopharyngeal nerve has several functions. It carries somatosensory sensations like touch, pain, and temperature from the posterior part of the tongue, hence the name glosso, and also the pharynx, hence the name glossopharyngeal nerve. It carries the taste sensations in the posterior 1/3 of the tongue and adjacent areas of the pharyngeal walls. It supplies baroreceptors in the carotid sinus and chemoreceptors in the carotid body by the carotid sinus nerve through general visceral sensory neurons, and supply parasympathetic secretomotor innervation to the parotid glands. Okay, it also supplies a single pair of muscles like the stylopharyngeus muscles. So you expect multiple nuclei from which the glossopharyngeal nerve originates. The glossopharyngeal nerve exits as fine rootlets from the upper part of the medulla behind the olive, and these rootlets join to form the nerves, the glossopharyngeal nerve, as they exit the skull through the jugular foramina. For more detailed description of the course of the glossopharyngeal nerve, you can refer to the lectures in the head and neck series. Now, each nerve passes down the pharyngeal wall before breaking into numerous fine nerves to form the pharyngeal plexus, together with branches of vagus. There is a lingual branch to the tongue, and carotid branch to the carotid bodies arise before the main nerve becomes the pharyngeal or forms the pharyngeal plexus. The cell bodies of the somatosensory neurons from the tongue, pharynx, and middle ear are situated in the small superior glossopharyngeal ganglion. Superior ganglia, the glossopharyngeal nerve has superior and inferior ganglia. This is the superior ganglia of the glossopharyngeal nerve. The central processes pass via the trigeminal spinal tract to end in the spinal nucleus of the trigeminal spinal nucleus complex, or the TSNC. The cell bodies of the sensory neurons from the taste buds in the posterior 1/3 of the tongue and adjacent areas are located in the inferior glossopharyngeal ganglion, and the central processes terminate in the upper part of the nucleus of the tractus solitarius, with taste neurons from the facial nerve. Now, the cell bodies of the general visceral sensory neurons are also situated in the inferior glossopharyngeal ganglion. The central processes end in the lower part of the tractus solitarius, where you can find reflex connections are made with the cardiovascular and respiratory centers in the medulla and with the hypothalamus, and all this to regulate the cardiovascular and respiratory activities. Also, the inferior salivatory nuclei are the only nuclei that can be clearly ascribed to the glossopharyngeal nerves and are the origin of the preganglionic parasympathetic neurons to the parotid gland. As mentioned before in the lecture about the facial nerve, the facial nerve supplies parasympathetic supply to the glands at the front of the face, beginning from the lacrimal and ending by the submandibular gland. But at the side of the face, the parasympathetic supply comes from the glossopharyngeal nerve. Each inferior salivatory nucleus lies immediately below the superior salivatory nucleus, and both nuclei have connections with the nucleus of tractus solitarius, trigeminal sensory nuclei, the olfactory system, and the hypothalamus. The connections mentioned are responsible for reflex salivary secretion in response to taste, jaw movement or oral sensation, and smell or motion. The preganglionic parasympathetic axons from the inferior salivatory nuclei supply the parotid glands, and also minor salivary glands in the lower lip and lower cheek, and glands in the mucous lining of the oral and laryngeal parts of the pharynx. The motor neurons to the stylopharyngeus muscle, which is derived from the third pharyngeal arch, begin in the upper part of the nucleus ambiguous of the vagus nerve. Remember that the muscles derived from the first pharyngeal arch supplied by trigeminal, the second pharyngeal arch supplied by facial, the third pharyngeal arch supplied by the glossopharyngeal nerve. The effects of damage to the glossopharyngeal or disease of the glossopharyngeal nerve. The most frequent cause of damage to the nerves are the compression by space-occupying lesions, means tumors or cysts forming in the pharynx, or posterior tongue, or direct invasion by malignant tumors in these areas. Also, it involves damage to the central sensory components within the brainstem, following, for example, a brainstem stroke or cerebrovascular accident. And the sensory nerves from the pharynx are the afferent components of the gag reflex, which is stimulated by touching the pharyngeal wall with a blunt object with the mouth open. If the mouth is closed, this initiates swallowing reflex to swallow the ingested food. I hope you got the maximum benefit from this lecture, and thank you very much for watching.